Welcome to the Michigan Trauma Quality Improvement Program. In this section of orientation, we will review hospital events. A hospital event is defined as a complication that occurred during the patient's stay at your hospital. The patient's stay begins on arrival to the emergency department or to the patient's room if a direct admit. Their stay ends upon discharge. For hospitals that may have an inpatient hospice service or unit, but do not have transition indicators such as discharge to hospice orders, a new encounter or visit number assigned, or change in admitting service to hospice, the end of stay for these patients occurs when the acute phase of care ends. This does not include comfort care status during the acute phase of care. Do not include complications that are present prior to patient arrival, such as a UTI noted and diagnosed by tests done in the ED. Do not report contaminated cultures that do not require treatment for infectious events. If, however, a provider documents a contaminant but treatment is still provided based on those results, the event should be reported. The complication codes correspond to the listed complications. Retired NTDS variable codes will still be indicated for variables that the MTQIP Collaborative continues to report. The complication date is the corresponding date when the complication was first recognized. Recognition of the condition is based on satisfying the criteria listed for the specific hospital event being identified. Abdominal compartment syndrome is a condition in which there is swelling and sudden increase in pressure within the abdominal space or fascial compartment that presses on and compromises blood vessels and end organ function. Report this hospital event if the abdomen must be opened or a percutaneous drain placed to lower the intra-abdominal pressure and relieve end organ dysfunction. Abdominal fascia left open is reported if the abdominal wall fascia was left open for any reason following first exploratory laparotomy. Acute kidney injury is reported for patients who did not require chronic renal replacement, such as dialysis, prior to injury, who has worsening renal dysfunction following injury, causing them to require this type of treatment during their hospital stay. If the patient or their guardians refuse renal replacement, the condition is still considered present if a combination of renal function and urine output criteria are present. Renal function criteria for capture includes an increased creatinine times 3 or a GFR decrease greater than 75%. Urine output criteria includes urine output less than 0.3 milliliters per kilogram per hour times 24 hours or anuria times 12 hours. Do not capture for patients receiving renal replacement therapy for the sole indication of drug clearance. Acute renal insufficiency is the reduced capacity of the kidneys to perform their function as evidenced by a rise in creatinine of greater than 2 milligrams per deciliter from baseline, but without requirement for dialysis. If there is no documentation regarding the patient's pre-injury renal function, assume a baseline creatinine value of 1.0. If a patient's renal functioning continues to decline to the point of meeting criteria for acute kidney injury capture, only report acute kidney injury. Acute respiratory distress syndrome, or ARDS, is a condition in which fluid collects in the lungs' air sacs, depriving organs of oxygen. ARDS has several areas of criteria that need to be met in order to capture. It occurs within 1 week of known clinical insult or new or worsening respiratory symptoms. Chest X-rays will demonstrate bilateral opacities that are not fully explained by effusions, lobe or lung collapse, or nodules. Common risk factors for edema related to ARDS include, but are not limited to, non-pulmonary sepsis, major trauma, pneumonia, pulmonary contusions, aspiration, and inhalation or burn injuries. To capture respiratory failure or edema cannot be fully explained by cardiac failure or fluid overload. The PaO2 to FiO2 ratio for capture criteria is less than or equal to 300 with a PEEP or CPAP of greater than or equal to 5 centimeters of H2O. The data dictionary includes a P to F ratio calculator for your convenience. Alcohol withdrawal syndrome is characterized by tremors, sweating, anxiety, agitation, depression, nausea, and malaise. It occurs 6 to 48 hours after cessation of alcohol consumption, and when uncomplicated, abates after 2 to 5 days. It may be complicated by grand mal seizures and may progress to delirium. Do not report if symptoms are present on arrival to your hospital or if withdrawal is caused from withdrawal from a substance other than alcohol. C. diff colitis is captured if it meets one or more of 3 criteria. These criteria consist of diarrhea plus a stool test that's positive for the presence of toxigenic C. diff or its toxins, or colonoscopy findings or histopathologic findings demonstrating pseudomembranous colitis. If a patient tests positive for the C. diff antigen but not for the toxin, please do not report. Cardiac arrest with CPR is reported for patients whose symptoms begin after arrival to your ED or hospital and of documentation of an episode of cardiac arrest requiring compressions, defibrillation, cardioversion, or cardiac pacing to restore spontaneous circulation. Do not capture for patients whose only cardiac arrest with CPR started prior to arrival. If you capture this hospital event, please enter the ICD-10 procedure code, date, and location for the corrective procedures taken, such as CPR or open cardiac massage, in your registry's procedures section. A catheter-associated urinary tract infection is defined as a UTI where an indwelling catheter was in place for greater than 2 calendar days on the date of event, with day of device placement being day 1. To meet capture criteria, the catheter must have been in place for more than 2 consecutive days and present for any portion of the day on the date of event or removed the day before. The patient must also have at least one sign or symptom from the list noted above and have a positive urine culture with no more than 2 organisms and at least 1 bacterium with a count of greater than 100,000. Only report patients who meet CDC NHSN Manual CAUTI Criterion SUTI 1A. A link to the manual is provided in the data dictionary for your reference. A central line-associated bloodstream infection is a laboratory-confirmed bloodstream infection where a central line or umbilical catheter was in place for greater than 2 calendar days on the date of event, with day of device placement being day 1. To meet capture criteria, the line must have been in place for more than 2 consecutive days and present for any portion of the day on the date of event or removed the day before. If a patient is transferred into your facility with an implanted central line or port in place, day 1 of first access is considered day 1. There are 2 different CDC criterion that can be used to capture this hospital event. These criterion are detailed above. Please pause this video if you want to review them at this time. Only report patients who meet CDC CLABSI criterion LCBI 1 or 2. Please note that criterion must be met within a 7-day infection window period. We have included a link for the CDC manual in the data dictionary for you to reference as needed. Deep incisional surgical site infections occur within 30 or 90 days of the NHSN operative procedure and include the deep soft tissues of the incision and has one of the following criteria: purulent drainage, spontaneous dehiscence, deliberate opening or aspiration by a physician with an identified organism, or if no testing is performed, the patient has either a fever greater than 38 degrees Celsius, or has localized pain or tenderness, or there's an abscess or other evidence of infection that is detected on exam or imaging. There is an included list of nonspecific selected NHSN operative procedures and their surveillance timeframes for your reference. A link to the CDC NHSN manual is provided in the data dictionary and is a good resource for determining what constitutes an operative procedure. Deep vein thrombosis is the formation, development, or existence of a blood clot or thrombus within the venous system. The patient must be treated with anticoagulation therapy, a vena cava filter, or clipping of the vena cava to meet criteria. If there is no anticoagulant treatment due to documented contradiction due to bleeding risks, a patient expires before treatment can be initiated, or a patient develops a non-extremity DVT, such as in the portal or internal jugular vein, but meets treatment criteria, please capture. Exclude thrombosis of superficial veins as well as patients with no documented contraindications who only receive aspirin as treatment. There are links provided under the resource section to help identify superficial versus deep extremity veins. Delirium is an acute onset of behaviors characterized by restlessness, delusions, and incoherence of thought and speech, which can often be traced to contributing factors such as medical illness, changes in metabolic balance, medication, infection, surgery, or drug withdrawal. Delirium can also be reported if there is a positive delirium screening tool such as CAM, or if there is a documented diagnosis of delirium in the patient's medical record. Do not capture for patients whose delirium is caused by alcohol withdrawal. Enterocutaneous fistula, or GI leak, is defined as a fistula of the GI tract to the skin, open wound, or body cavity resulting from injury, breakdown, or leak of GI anastomosis. This is typically documented in the patient physical exam or by radiologic study with the presence of leakage of GI contents or contrast. Extremity compartment syndrome is described as documentation of tense muscular compartments of an extremity through clinical assessment or direct measurement of intercompartmental pressures requiring a fasciotomy. Report as a hospital event if it's originally missed, leading to late recognition, a need for late intervention, and has threatened limb viability. Exclude if a fasciotomy is performed prophylactically without evidence of elevated compartment pressures greater than 25 millimeters of mercury. To capture myocardial infarction as a hospital event, an acute myocardial infarction must be noted in the patient's medical record, along with ECG changes indicative of an MI. There must also be an elevation in troponin levels greater than 3 times the upper level of the reference range. Physician documentation of an acute MI that occurred after arrival to your center also needs to be present for capture. Organ space surgical site infections are infections that occur within 30 or 90 days after an NHSN operative procedure according to the list in the selected operative procedures table. You can review this table by clicking on the link in the data dictionary under the description area. To meet capture criteria, the infection must involve any part of the body deeper than the fascial or muscle layers that are opened or manipulated during the operative procedure. The patient must also have either purulent drainage from a drain that is placed into the organ space, an identified organism, or an abscess or other evidence of infection that is detected on exam or imaging. To meet criteria, the infection must also meet at least one criterion for a specific organ space infection site listed in the specified sites of an organ space SSI. These criteria are found in the surveillance descriptions for specific types of infections chapter. Please report this hospital event for patients that had a chest tube placed and then developed an empyema that required management with placement of a new chest tube, VATS drainage, or thoracentesis with positive culture. There are links for the CDC NHSN manual, as well as frequently asked questions in the data dictionary for your reference. Osteomyelitis must meet at least one of the following criteria for capture: an organism identified from bone, evidence of osteomyelitis on a gross anatomic or histopathologic exam, or patient has at least 2 localized signs and symptoms, including temperature greater than 38 degrees Celsius, swelling, pain, heat, and drainage. These symptoms must not have any other recognized cause. The patient must also have either an organism identified from blood testing or imaging test evidence suggestive of infection, which, if equivocal, is supported by clinical correlation, specifically physician documentation of antimicrobial treatment for osteomyelitis. There are links for the CDC NHSN manual provided under the resource section for your reference. Report other post-injury complications noted in physician documentation and requiring treatment that are not specified on the NTDS or MTQIP Hospital Events lists. To report pneumonia, patients must meet one of 2 criterion. The first criterion consists of 3 CDC pneumonia algorithms. The patient must meet the criteria as listed under imaging test evidence, signs and symptoms, and laboratory columns in one of the 3 algorithms. Links for these algorithms are available in the data dictionary for your convenience. The second criterion for reporting pneumonia are patients that meet capture criteria for ventilator-associated pneumonia. In this scenario, please report both VAP and pneumonia. There are helpful CDC and HSN links in the data dictionary for references needed. A pressure ulcer is a localized injury to the skin and/or underlying tissue, usually over a bony prominence, as a result of pressure or pressure in combination with shear. Please report any MTQIP stage 2 to 4 ulcers. Obscured full-thickness skin and tissue loss or instageable pressure ulcers are also included for reporting. Exclude intact skin with non-blanching redness or stage 1 pressure ulcers. Pressure ulcers that are present on arrival and progress to a greater stage during the hospital stay, or medical device-related mucosal membrane pressure ulcers. There is a link for the MTQIP pressure injury stages provided under Resources for reference. A pulmonary embolism is the lodging of a blood clot in the pulmonary artery with subsequent obstruction of blood supply to the lung parenchyma. The blood clots usually originate from the deep leg veins or the pelvic venous system. Include segmental PEs as well as fat embolisms noted on pulmonary imaging. Do not report subsegmental PEs. Consider the condition present if the patient has a VQ scan that is interpreted as high probability of pulmonary embolism or a positive pulmonary arteriogram or positive CT angiogram. Sepsis is a life-threatening organ dysfunction due to a dysregulated host response to infection. Septic shock is defined as a subset of sepsis in which profound circulatory, cellular, and metabolic abnormalities substantially increase mortality. For reporting, the patient must have a culture-confirmed infection. They must also demonstrate at least 2 of the following organ failure criteria: altered mentation or a Glasgow Coma scale less than 15, a systolic blood pressure less than or equal to 100, and a respiratory rate greater than or equal to 22 breaths a minute. Another way to capture is if the patient meets the criteria for septic shock, which is persistent hypotension requiring vasopressors to maintain a MAP of greater than or equal to 65, and a serum lactate level greater than 2 millimoles per liter or 18 milligrams per deciliter, despite adequate volume resuscitation. Please use the link provided in the data dictionary for reference or if clarification is needed. A stroke or CVA is described as focal or global neurological deficit of rapid onset that is not present on admission. The patient must also have a duration of neurological deficit greater than or equal to 24 hours and demonstrate at least one of the listed symptoms, such as change in level of consciousness, hemiplegia, or sensory loss affecting one side of the body. Also report for patients with a deficit duration of less than 24 hours if neuroimaging documents a new hemorrhage or infarct consistent with stroke, or therapeutic interventions were performed for stroke, or the neurological deficit results in death and there are no other readily identifiable non-stroke causes, and the diagnosis is confirmed by neurology or neurosurgery or by the listed procedures. Although the neurologic deficit must not be present on admission, risk factors predisposing to stroke, such as blunt cerebrovascular injury or dysrhythmia, may be present on admission. A superficial incisional surgical site infection occurs within 30 days after any NHSN operative procedure, where day 1 is the procedure date. It involves only skin and subcutaneous tissue of the incision. It must also meet at least one of the 4 listed criteria. Please pause the video to review. There are 2 specific types of superficial incisional SSIs, primary and secondary. Both can be used for reporting. There are links for the CDC NHSN manual included in the data dictionary for your use. Patients admitted to the ICU after initial transfer to the floor and/or patients with an unplanned return to the ICU after initial ICU discharge are captured for the unplanned admission to ICU hospital event. Include patients who require ICU care post-op due to an event that occurred during the surgery or in the PACU. Do not include patients with a planned post-op ICU stay documented as such in the EMR. Unplanned intubation is reported for patients requiring placement of an endotracheal tube and mechanical or assisted ventilation manifested by severe respiratory distress, hypoxia, hypercarbia, or respiratory acidosis. For patients who were intubated in the field emergency department, or those intubated for surgery, unplanned intubation occurs if they require re-intubation greater than 24 hours after they were extubated. If a patient is intubated as part of resuscitation for an unwitnessed CPA, please capture unplanned intubation. Even though not witnessed, if the patient is not breathing, they meet the criteria of hypoxia. Patients who are intubated for reasons other than the respiratory issues listed, such as a change in mental status and airway protection, do not meet the definition criteria and should not be reported. Patients with an unplanned operative procedure or patients returning to the operating room after initial operation management of a related previous procedure meet the capture criteria for unplanned visit to the operating room. Do not include pre-planned or staged procedures or procedures for incidental findings. Unplanned is defined as an acute clinical deterioration requiring operative intervention. Deterioration can be seen in different forms, such as hemodynamic, neurologic, worsening injuries such as an increased intracranial bleed noted on imaging, or lab findings such as decrease in hemoglobin. Ventilator-associated pneumonia is a pneumonia where the patient is on mechanical ventilation for greater than 2 consecutive calendar days on the date of event, with day of ventilator placement being day 1. The ventilator must be in place on the date of event or the day before. To report this hospital event, the patient must also meet the criteria as listed under the imaging test evidence, signs and symptoms, and laboratory columns in one of the 3 algorithms. Links for these algorithms are available in the data dictionary for your convenience. If no quantitative culture is performed, report if the culture is positive. There are links for the CDC NHSN manual included in the data dictionary for your use. Wound disruption is the separation of the layers of a surgical wound, which may be partial or complete, with disruption of the fascia. Thank you for watching.